So thank you again for everyone joining us today. I did want to let you know that to stay on mute until the end, we'll take questions at the end. And there's also a little chat function. In the top right-hand corner, there's a little speaking bubble that you can click on and submit any questions, and we will get to those at the end. And I'd like to take a moment now to just introduce Dr. Olsen. She is one of our MAX consultants who will be presenting today. Dr. Olsen is an addiction medicine specialist trained in internal medicine. She teaches appropriate opioid prescribing to primary care physicians and instructs on medical co-occurring conditions to psychiatrists and other behavioral health providers. She currently serves as medical director of the Institutes for Behavioral Resources, Inc., REACH Health Services in Baltimore. This is an outpatient substance use disorder treatment program that provides a broad range of services and includes a health home. She has previously served as the Vice President of Clinical Affairs for the Baltimore Substance Abuse Systems, as well as the Deputy Health Officer for Harford County Health Department, where she oversaw the local substance use treatment services, and was the Medical Director for the Johns Hopkins Hospital Outpatient Substance Use Treatment Services. So thank you all for joining, and thank you to Dr. Olsen for coming and speaking with us today, and I will pass it on over to her.
Great. Thank you very much, and thank you for that introduction. And it is really exciting to be here for our inaugural MAX webinar. Just as a reminder, please put yourselves on mute until the end, and we will let you know when it is time for questions. If you have questions throughout the webinar, please don't hesitate to use that chat box function, and we'll get to those at the end as well. Just a couple of disclaimers that this training is really for informational purposes only, and the content has not been endorsed or approved by the American Society of Addiction Medicine. We will be making a lot of reference to ASAM, but the content is our own. And also that Maryland's behavioral health system references really those services that are funded by public dollars, so meaning Medicaid and federal and state grant funds, and that commercially funded services may vary. So what you see in today's presentation may not apply to commercial insurers such as Care First, Blue Cross Blue Shield, Cigna, Aetna, and others. But we hope that by the end of this presentation that the participants really should be able to do three things. One, describe the ASAM level of care continuum. Two, identify how Maryland structures its specialty behavioral health system in accordance with ASAM levels of care. And three, understand how to effectively and efficiently access specialty behavioral health system services and resources for patients. So just a brief word about the American Society of Addiction Medicine. So ASAM is a professional society of physicians, clinicians, and associated professionals, numbering now over 5,000 across the country in addiction medicine, who all have a focus on education and treatment in particular. And the ASAM patient placement criteria that we're going to go through and the continuum of care that we're going to go through in this webinar was developed initially in the late 1980s after over 50 sets of different criteria from a variety of different payers were put together on treatment eligibility, different service types, and there was a lot of confusion about who could access addiction treatment services, what type of services, and for how long. So ASAM at the time brought together a group of special experts and providers and developed what was then called the ASAM patient placement criteria. That set of guidelines, standards has been revised several times since 1991, most recently a few years ago, and now is really known as the ASAM criteria. And essentially, what the ASAM criteria provides is a common nomenclature for really describing the continuum of addiction treatment services from very low intensity up to a very high intensity. And has developed and provides a comprehensive set of guidelines then for placement, continued stay, and transfer or discharge of patients who have addiction and co-occurring conditions kind of across that continuum. It is currently in use in over 30 states, including Maryland. So there are a couple of different ways that I think about kind of this continuum of care. You can think about it longitudinally, but I really think about it as kind of a circular or really kind of across different directions. So from three big buckets, one being outpatient services, two being residential services, or kind of those subacute services, and then the third big bucket is being kind of acute hospital care. And people can move between these different buckets depending on the intensity of their symptomatology at a given point in time. And that is really the goal, to kind of match the intensity of the intervention with the intensity of the symptomatology. And we'll talk a little bit about how ASAM and how in Maryland we do that. So ASAM thinks about this as in kind of a continuum along a parallel, so or along a line, which is the other way to kind of think about this. And diving a little more deeply, you can see that ASAM really defines the various different levels of care, all the way from kind of zero or no care through early intervention, which is primarily for people who currently do not meet diagnostic criteria for a substance use disorder, all the way through kind of outpatient services and different intensities of outpatient services, then to the various different residential services, or more of those kind of subacute, if you were thinking it in terms of a medical analogy, almost like subacute care facilities, and then all the way up to level 4, which are the medically managed intensive inpatient services, which really align with kind of acute inpatient hospital care. And we're going to go through some of these a little bit in more detail. So you may have heard of these various different levels of care described in other terms, and there are a lot of different terms out there. So this chart really tries to align some of the various different terms with the different ASAM levels of care. So for example, level of care 0.5, or early intervention, is really where there is assessment and education of at-risk individuals who, as I mentioned, do not meet those criteria for a substance use disorder or meet criteria for substance use treatment. Level 1 is your standard outpatient, which is defined typically as less than 9 hours of service per week for adults, or less than 6 hours per week for adolescents, and involve recovery or motivational enhancement services. Level of care 1, so you see there are 2 levels of care here, one OP or outpatient, and the other termed OPT or OTP, which essentially is outpatient or opioid treatment programs. And that is really a structured daily or several times weekly opioid agonist medication delivery service, plus counseling and other medical services that are available to help people maintain their stability, especially when they have moderate to severe opiate use disorder. So these are really kind of the federally very heavily regulated opioid treatment programs, or OTPs, where people can receive methadone, and that is the only place they can actually receive methadone. Level 2.1 is intensive outpatient, defined as 9 hours or more per week for adults, or more than 6 hours per week for adolescents. And then level 2.5, which is for people who need 20 hours or more per week, but who really don't require 24-hour care. And then you get into level 3.1, 3.3, 3.5, and 3.7, which are all also known as RCTs, or residential treatment centers, sometimes also referred to as intermediate care facilities. So again, thinking a little bit in terms of the medical analogy of subacute rehab facilities or subacute nursing facilities. And these really are where there is 24-hour structure with available trained personnel, but those staff vary depending on the level of care and the level of intensity of services that individuals need. So for example, level 3.1 is really the least intense, sometimes also referred to as the old halfway house, where there is 5 hours per week of clinical service, but really not designed for very medically complicated or people who have subacute medical needs or subacute psychiatric needs. All the way to 3.3, 3.5, where there are trained counselors to help stabilize imminent danger, where people can function even with other medical and psychiatric comorbidities that they might have. And then up to 3.7, where there is essentially 24-hour nursing care with physician availability for really significant problems. And we're going to talk more about the various different dimensions and how that actually impacts where somebody might receive the most appropriate level of care. And then level 4, which is the inpatient hospital. So for someone who has an emergent medical or psychiatric issue that really can't be managed and is most appropriately managed in an inpatient setting. So just a few notes to make on that explanation. So if you notice, most of the levels of care are actually described in terms of their intensity of counseling and other behavioral interventions. And that intensity of counseling is described as the number of hours of service, which ASAM really thinks about in terms of kind of that is the dose of treatment that people receive in the various different levels of care. Because we don't have any other ways of measuring the number or the amount of behavioral interventions that individuals receive, this is how one way of really kind of thinking about that from a quantitative perspective. The other thing to note is that there's no mention of withdrawal management in any of what I've told you so far. And that withdrawal management, or what used to be referred to as detox, can actually be an adjunct to any level of care with the appropriate staffing that is based on the types of withdrawal management offered. And ASAM does have and designates different levels of care with a WM if that is what they actually are able to provide. And finally, that even though there is a designation of an opioid treatment program where opioid agonist therapy such as methadone can be provided, that ASAM also notes that essentially continuous opioid agonist, whether methadone or buprenorphine, and antagonist medications, injectable naltrexone, for example, can actually be provided across different settings and different levels of care with collaborations as needed. So not every level 3.7 may also have an opioid treatment program, but that coordinating with an opioid treatment program can allow a patient to stay on their opioid agonist therapy even during a stay in a level 3.7. So how does Maryland Specialty Behavioral Health System then incorporate ASAM, and what does the system look like, and who manages this system? Well, so it turns out that before January 1st of 2015, some of you may remember, the public funding for addiction treatment really rested with Medicaid MCOs and the Alcohol and Drug Abuse Administration, which since 2015 has merged, or even before 2015, merged with the Mental Hygiene Administration to form the Behavioral Health Administration. And then starting January 1st of that year, 2015, Beacon Health Options received the contract to begin managing this newly formed public behavioral health system that includes both substance use treatment services as well as mental health services and integrated services. And Maryland's public funding for substance use disorders is based on regulations that actually specify the ASAM levels of care as the framework for how Maryland really thinks about its continuum of services, specialty services in particular. So what does that continuum then kind of look like, and how robust is Maryland's system compared to, for example, other states? Well, we are lucky in Maryland that we actually have really almost the entire continuum. That may not be the case in absolutely every jurisdiction, but across the board, we stand far ahead of many other states in terms of our availability and our implementation of the ASAM continuum. So this slide really shows you what Maryland Medicaid reimburses in terms of services provided in the different levels of care. So all the way from outpatient treatment, that outpatient ASAM level 1.0, all the way to inpatient withdrawal management, that ASAM level 4.0. Of note, in May of 2015, that second bullet here, number 2, opioid treatment program, that is also designated as an ASAM level 1.0, partly because the level of counseling provided in OTPs is the same as that ASAM level 1.0 that you see above. But starting in May of 2015, Medicaid rebundled many of the services that actually at one time were paid for just as one whole big bundle. So now people can receive separately medication bundle, either methadone or buprenorphine, so that when they are in another level of care, such as an intensive outpatient program or in a level 3 residential facility, for example, they can continue to receive their medication, and both sets of providers can be reimbursed for delivering those services. Counseling services, medical services, and health home services are then also reimbursed for and billed for separately in an opioid treatment program, even though the regulations really speak to the need for providing all of those services, particularly the counseling and medical services, to patients for optimal outcomes and optimal care. So as you can see, there are some asterisks here, partly because the continuum of care for individuals in these levels of care, both outpatient, intensive outpatient, and the community and hospital-based partial hospitalization programs are all Medicaid reimbursed and have been Medicaid reimbursed even prior to the reimbursement for the ambulatory care services. Number 5, 6, and for the residential services. So number 6 and 7, those levels of care have been Medicaid reimbursable since July 1st of 2017. And I would also add that the asterisk really speaks to that there are medications that can be added, so particularly buprenorphine and injectable naltrexone can be added as adjuncts to outpatient treatment, intensive outpatient treatment, or the community and hospital-based partial hospitalization program, even though you don't see those here separately as you do in the opioid treatment program. Ambulatory withdrawal management is something that ASAM has levels for. It is not referenced that way in the Maryland Medicaid or the specialty behavioral health system, but is something that can be reimbursed. But there are some other services that are available to people in Maryland through the support of federal and or state grant-funded services, including this same continuum of specialty addiction treatment services for those who are uninsured or underinsured, and that includes individuals who are covered only by Medicare. Medicare does not cover, for example, treatment in opioid treatment programs, and so therefore they are really considered underinsured from that perspective by Maryland. And there are funds then that can be provided or accessed to help support individuals with Medicare for that treatment if that's what they need. Early intervention is also something that is grant funded and grant supported because it does not involve diagnoses, so it is not a Medicaid reimbursable level of care at this point. That halfway house, ASAM level 3.1, is something that currently is only state or federally grant funded in Maryland, but that will change come January 1st of 2019 when Medicaid will also provide some limited reimbursement for this level of care as it does for the other ASAM level 3 levels of care and services provided there. And then there is a range of recovery support services from case management coordination to recovery coaching, recovery supported housing, and transportation vouchers that are provided particularly through something called the Maryland Recovery Net that is also available to individuals and supported by federal and state grant funds, and again also managed by the Beacon Health Options. So what about care outside of the specialty behavioral health system? What can individuals, providers, practitioners in primary care expect or be able to deliver in these non-specialty settings? So there are a few different sets of services, including screening, brief intervention, and referral to treatment that are reimbursable in non-specialty settings, and that includes primary care, emergency departments, even in jails or detention centers and hospitals. Through the MCOs, Maryland Medicaid also covers office-based opiate addiction treatment with buprenorphine or injectable naltrexone that is really integrated into primary care or other ambulatory non-specialty settings, such as emergency departments or hospitals. And there is room to expand that and efforts to expand all of this within the state. Other substance use disorder management, such as for alcohol use disorder, for example, can also be integrated into primary care or other ambulatory non-specialty settings, and again would then be covered through the MCOs. So there are many different points of access, many different sets of services that individuals can receive to really help support their addiction treatment and recovery. Well, so how do you then determine, or how does someone determine what appropriate level of care they should receive? It's great to have a lot of different options, but sometimes it gets kind of confusing with all those different options. So how do we really think about recommending or referring people to one level of care versus another? Well, so it starts really with having a system that can match services to individually assessed needs, because not everybody with an opiate use disorder is going to have the same severity of their opiate use disorder or have the same other comorbid conditions that may complicate their overall clinical picture, or have the same recovery capital, such as housing and other supports that may also contribute to their overall prognosis with treatment and recovery. And it's important to really think about these different levels of care, that even though they are defined by numbers or acronyms, that they're really not separate structures, but they represent this continuum, and so people should be able to move between one and another with relative ease and as their condition and as their needs dictate. And so ASAM, as well as Maryland, really is striving to move away from kind of fixed lengths of stay towards these clinically driven interventions that have expressed intention and evaluated results. Again, really, it's not that 90 days is going to be what may fit any one given individual, or 28 days or 6 months, but really looking at how people are actually responding to the intervention and what outcomes and what treatment goals they may have for themselves. So the appropriate level of care really is that which is the least intensive while still meeting treatment objectives and providing safety and security for the patient. Well, that's all well and good, but how do we practically really do this? Well, one way to think about, and one way that ASAM really thinks about kind of matching the symptomatology to the intensity of the services, is to think about the symptoms across 6 different dimensions. It starts with symptoms in the intoxication and withdrawal potential. So if somebody is acutely alcohol intoxicated and may be at risk for alcohol poisoning, that may become of prime concern because that is what is really going to affect the person in the most imminent way. And so in that situation, perhaps the best place for that person to receive initial care is in an acute inpatient hospital. Secondly, what other biomedical conditions does the person have? So do they have endocarditis, for example, or do they have really severe wounds and abscesses? Well, that would speak to that they probably need more emergent medical care, perhaps again in an acute inpatient hospital. But let's say somebody has a chronic medical condition, such as diabetes, that's not very well controlled. Well, that actually may not be as emergent, and so therefore the need for kind of higher levels of care may not be quite as imminent or as weighty. The third category is really emotional, cognitive, or behavioral conditions. So is the person actively suicidal or passively suicidal? Do they have other emotional or behavioral conditions or other psychiatric conditions that make it difficult for them to really understand what is happening around them? Do they have symptoms of psychosis, or are they so depressed that being in a place where that depression really can be appropriately addressed may also factor into the decision about level of care recommendation. So the first 3 dimensions, 1, 2, and 3, as you can probably see, are the most important in terms of really helping to decide on what is the imminent danger to the person or to those people around them, but primarily to the individual person, and what setting is best initially to help the person stabilize with whatever acute conditions may be happening in those 3 areas. 4, 5, and 6, readiness to change, relapse potential, recovery, and living environment, are then also considered in deciding if 1, 2, and 3 are more stable, what other factors may impact that individual's ability to engage in treatment at a particular level of care or sustain the treatment services or also put them at risk then for safety if they are continuing to live in their recovery and living environment and have a high risk for relapse. The readiness to change one is sometimes a hard one to really get at because addiction, unfortunately, as many of you probably know, is characterized by often people being very pre-contemplative about stopping their use. And while the other dimensions and the assessment of where they are in terms of their other dimensions may point in a direction to a higher level of care, if the individual is very pre-contemplative about their disease, that level of care may actually not be as effective, or the services provided in those levels of care may not be as effective because the person actually is really unable to engage or even stay in a level of care that is mismatched to where they are in terms of their readiness to change. So something to keep in mind. So one of the ways, perhaps in the not quite as structured or a briefer way of thinking about these dimensions, because there are some sophisticated tools out there that can help gather information, and then develop a recommendation for a specific level of care. But one way of kind of doing that perhaps a little quicker is to think about, well, what does the patient want and why now? What life areas or dimensions are most important in determining treatment priorities? So is it that they have an acute medical issue or acute psychiatric issue? Do they have a chronic medical condition for which outpatient care would be appropriate? What specific services and service parameters are most appropriate given the answers to the other two questions? And what is the outcome of the treatment plan and placement decision? So what does the person really want for themselves? Are they interested in taking a medication for an opiate use disorder, for example, that might help them feel better, even in the short term and then also the long term? And are they willing to do that? Or are they looking for something to provide really immediate relief, and then with discussion perhaps ongoing about what other treatment and support services may be helpful? So again, kind of coming back to some extent, at least initially, this idea of matching the intensity of the intervention with the intensity of the symptomatology, and thinking initially about these three big buckets. So the residential, acute hospital, or outpatient level of care, and where that person is in terms of what is going to put them at imminent risk, what are they willing to do, and what are their kind of complex or compilation of needs and wants. So here's just another example, or one example, of somebody who may typically be a good candidate for residential care. So someone who is an adult, more than 18 years old, who may have a polysubstance use disorder, including alcohol and or benzodiazepines, and in whom alcohol and benzodiazepine withdrawal really would require medical management and monitoring. Let's say they have a history of DTs or alcohol or benzodiazepine withdrawal seizures. Let's say they have a very severe form of either alcohol or benzodiazepine use disorder, in which the expected withdrawal would be very severe. Of note, opiate use disorders really can be pretty well effectively managed in outpatient settings with medications such as opiate agonist therapies or opiate antagonist. And so people who have, particularly adults, non-pregnant, who have opiate use disorders as really their primary condition, don't in and of themselves really need to be in a residential level of care. Individuals who have no acute medical issues needing acute hospital care, as we've talked about. So if you had somebody who had acute pancreatitis or unexplained fever, and someone who uses it intravenously, that might make you concerned about an acute infectious process related to that, they probably, initially at least, would be best served in an acute hospital. Individuals who are not actively suicidal or homicidal, but may have had passive thoughts of suicide in the past or remote attempts, may not need acute inpatient care, but could be served in a residential setting where co-occurring services are also provided. Someone who is motivated at the moment for treatment is somebody who also, in combination with these other factors, would be appropriate for residential care, because if they're not motivated, they may need that level of care, but perhaps are unwilling to access that service. And individuals who have unstable housing and a high relapse potential. So all these factors combined may lead one to think this is somebody who would typically be appropriate for a residential level of care, and may at the higher levels, such as 3.7 with withdrawal management that could address the alcohol and benzodiazepine withdrawal, at least initially, and then have the person step down to a lower level of care as their risk for medical complications related to the withdrawals subside. So just a quick word about special populations, because sometimes there are questions about, well, what about adolescents and pregnant women? And particularly for residential care, adolescents have a lower threshold because they need some more focus on sustaining motivation for treatment. And sometimes that can be best and most effectively and efficiently provided actually in a residential level of care. And they also tend to have fewer biomedical issues that would need acute inpatient services, for example. Pregnant women are another special population for whom we may have a lower threshold for residential care, and it may need to be residential care that has accommodations for other children, as they may have them in their custody as well. And the reason for having a lower threshold for residential care is that there may need to be more focus on medical monitoring due to the pregnancy. This is particularly the case for pregnant women who use alcohol, benzodiazepines, cocaine. For opioids, however, if that is really the primary substance use disorder present, pregnant women also will do very well in outpatient care with methadone or buprenorphine. So just a word about how to then access these specialty addiction services. There are several different ways, and there are several different resources. So the first is a website called mddestinationrecovery.org that will take you to the overdose prevention page at the Behavioral Health Administration of Maryland, in which there are a number of different good resources, documents, and ways of getting in touch with many of the other resources that are on this slide, including the Maryland Crisis Hotline number that is listed here. Beacon Health Options, as the administrator of the public behavioral health system, is also a resource for accessing specialty addiction services and other mental health services as well. Some of the local health departments across the state are now providing walk-in assessments at various different times or days of the week. And on the Maryland Destination Recovery website, there is a link to a matrix that will provide some of that specific information. And before it's too late, .maryland.gov is another website that has links to a number of the various different ways of accessing specialty addiction services. And this is just a screenshot of what that Before It's Too Late website looks like. When you go to the home page and then click on resources, this is where it will get you. And here you can also get linked to that Get Help Now website. There are ways of finding and some resource directories to find treatment by county, ways of identifying resources to find your local health department, and the crisis hotline, as we mentioned, that 1-800-422-0009 number. So we couldn't talk about accessing specialty addiction or addiction treatment services and resources without mentioning the Maryland Addictions Consultation Service, because that is the service that through which this webinar is being provided. And this is a phone consultation service via a warm line, kind of through a telephone, that can provide answers to some clinical questions, particularly related to the provision of buprenorphine, but also resources for physicians, other prescribers, and general referral information for healthcare practitioners who are trying to access resources and services for their patients. It is not a line that patients themselves would be able to access. That really is the crisis service line that I showed you earlier. Max also is holding continuing education training opportunities, such as this one, related to opiate use disorders and other SUDs in the future, and serves as a resource and referral networking site in terms of assistance for identifying addiction and other behavioral health resources that meet the needs of patients. So we are very happy to be part of this webinar, this consultation service in conjunction with the University of Maryland Department of Psychiatry. So please fill out an evaluation for this webinar. The link is here on this slide. And with that, we will take questions. So are there any questions? So there's one question in the chat box. Oh, and that is the evaluation. So any questions? If you want to unmute yourselves, please feel free to do that. Or if you want to type a question into the chat box, please feel free to do that as well. Well, so hearing no questions in the chat box. This webinar has been recorded and will be available on the MACS website, as well as most likely links to other websites. So please feel free to disseminate it freely. And oh, did someone want to ask a question?
I did. What is the MACS website?
Oh, so let me go back to the past slide for you. The MACS website.
I'm on the phone, so I can't see any of the slides.
Oh, okay.
If you go to Maryland MACS, so Maryland, capital MACS.org.
Thank you.
Great. Well, with that, thank you all for joining us today, and we look forward to having you join us either through MACS or also through other webinars that we will be holding in the future. Have a great afternoon.